Hello everyone, my name is Orlando Rodriguez and I am an internal medicine resident at Larkin Community Hospital South Miami. Today, I will be presenting a case of sustained ventricular tachycardia as the initial manifestation of severe non-ischemic cardiomyopathy with complete recovery following guideline-directed medical therapy. Sustained ventricular tachycardia is most commonly associated with ischemic cardiomyopathy or advanced structural heart disease. However, in rare cases, it may be the first presentation of severe non-ischemic cardiomyopathy. Early recognition is critical, as timely initiation of guideline-directed medical therapy can significantly alter patient outcomes. Our patient was a 56-year-old male with a history of hypertension and obesity who presented with acute onset dyspnea and palpitation of 1 day duration. He denied chest pain, syncope, or infectious symptoms. On examination, jugular venous dissension, lower extremity edema, and diminished breath sounds were found. Electrocardiography revealed sustained monomorphic ventricular tachycardia. The patient was treated with intravenous amiodarone and beta blocker therapy, resulting in termination of the arrhythmia, along with intravenous loop diuretics with improvement of lower extremity edema. Transthoracic echocardiography demonstrated severe systolic dysfunction with a left ventricular ejection fraction of 15%, global hypokinesis, moderate left ventricular dilation, bilateral enlargement, and dilated inferior vena cava, consistent with elevated right atrial pressure. Following resolution of ventricular tachycardia, the patient developed atrial fibrillation with rapid ventricular response. Transesophageal echocardiography and synchronized electrical cardioversion were performed, successfully restoring to sinus rhythm. To determine the underlying etiology, diagnostic coronary angiography was performed and demonstrated normal coronary arteries, excluding ischemic cardiomyopathy and supporting a diagnosis of severe non-ischemic cardiomyopathy. The patient was initiated on comprehensive guideline-directed medical therapy, including sacubitril valsartan, carvedilol, spironolactone, and dapagliflozin. Anticoagulation with apixaban was started, and the patient was discharged with a wearable cardioverted defibrillator for temporary arrhythmic risk mitigation. At 3 months follow-up, repeat echocardiography demonstrated improvement in ejection fraction from 15 to 30%. At 1 year follow-up, left ventricular function had completely recovered, with normalization of ejection fraction to 56%. The patient remained clinically stable with a recurrence of ventricular tachycardia or atrial fibrillation. This case highlights that sustained ventricular tachycardia may be the initial manifestation of non-ischemic cardiomyopathy and emphasizes that severe systolic dysfunction at presentation does not necessarily represent irreversible myocardial injury. Early rhythm stabilization, exclusion of ischemic disease, and prompt initiation of guideline-directed medical therapy can lead to complete myocardial recovery. Thank you for your time.